Thank you for the kind introduction, and thank you also to Sky for the opportunity to speak today. So we've talked a lot about symptoms, and my 78-year-old patient that I'll be presenting today was very symptomatic and the father of a cardiologist. So in all aspects, this procedure is justified, as a full disclosure. He was hypertensive, diabetic, and dyslipidemic, and of course, as I said, very symptomatic over the last few weeks, despite being on optimal guideline-directed medical therapy, and had a preserved ejection fraction, so no question of viability either. It was a stable CCS case that we thought would be pretty straightforward. So we proceeded transradially as is usual, and as you can see, there's a very tight stenosis in the mid-left circumflex. There's some mild to moderate disease in the LAD, which we didn't think much of, and decided that this circ was indeed the culprit that we needed to revascularize. RCA also, the distal RCA, there was a moderate lesion. I didn't include the other pictures for ease. So we've presumed this was the culprit and therefore decided that it was a pretty straightforward, seemingly not too much over type A lesion. Proceeded to wire the circ lesion, and went with an extra backup 3.56 for better support because it was a mid-LCX lesion and these circumflex lesions are notorious. And that's when we realized that it wasn't as straightforward as it might have seemed, and the ballooning was not as easy as we thought it was as well. So this was a 210 balloon, which we tried to manipulate across, but just managed to inflate. And this is the next picture. So at that point, I mean, you don't speculate what happened, you just try to fix it as soon as possible with as little compromise to the patient as possible. And this is, mind you, a father of a cardiologist. So the patient started sinking rapidly. We had an adrenaline surge. Now, what to do? Of course, it was not a straightforward, straight-cut circumflex lesion. We now have a full-blown left main LAD involvement, presumably a dissection. We decide, I mean, there really isn't time to think what went wrong there. You see the patient's hemodynamics sinking right in front of you. We don't have Impella. We don't have the luxury of that, nor the expertise of having an IBP put in right then and there. So we have to really fix these type of lesions without much MCS support. And therefore, the operator then proceeded to wire the perfect LAD immediately. And at that time, we also thought it could be thrombus, although, I mean, it's very unlikely, and it was most probably a dissection. So the LAD was then wired, and yet this appearance remained. So things are getting worse. What to do? We saw that there was the dissection plane extending across the left main also. So what to do? Because the patient is in dire hemodynamics, we need to also think of now not just stenting into the left main, to think of an upfront two-stent strategy, because this is a distal left main bifurcation dissection. And in that case, which vessel to stent first, and indeed which strategy? So because we knew there was already a very tight lesion in the left circumflex and the wire was initially there, we figured that might be where the biggest dissection plane was, and decided to choose the left main to LCX. We stented that with a 3.5 30 millimeter drug-eluting stent. And then we found that what little flow was in the LAD was also totally occluded. So what to do next? This would necessarily necessitate a bailout two-stent strategy. There was, ideally, you would have to have done a pot at this point. There was no time to pot. Immediately, we gave some nitro to see if there was any restoration of flow, but not really. So we took a small 2.5 10 NC balloon and just inflated that ostial circ to see some flow so that we would be able to visualize some degree of a landing zone and size the stent. And here it's very obvious there that the dissection plane is extended right up to the mid-LAD. And so we then went for an inverted tap where we stented in. We did a pot at that point because we saw that there was some flow established, and then went for stenting of the left main back into the LAD in an inverted tap. So here, essentially, in typical conventional bifurcation jargon, the circumflex would be considered the main branch. And we took a 2.75 38 millimeter stent into the left main, pulled that back, took a balloon in the circ, and did a kissing balloon inflation and a final pot. And at this point, of course, the patient stabilized, so we had the opportunity to perform an IVUS study extending from the LAD. We didn't do the whole through the circ, we just did it through the LAD and made sure that the left main stent was well opposed. And this is the final angiographic picture, and he's well at 6-month follow-up. So for left main bifurcation, the provisional strategy is to be adopted until the side branch becomes compromised. Dr. Imad Shaban showed a quite similar case this morning with, however, depressed ejection fraction, and he had an impella in. It's important to be aware of guide cath-induced dissections, particularly the notorious extra backup guides, and particularly early on in your career. So I personally prefer the JL. All the trials highlight the importance of operator expertise and choice of strategy, and I think this is even more relevant in terms of bailout, and I think that TAP is probably the best technique to use in case of this sort of bailout, unless you want to do an SKS, which isn't really recommended. And it's also important to keep the procedure as simple as possible, simple, safe, and swift. So not choosing to do that part, it was an essential step in a regular bifurcation, but we deliberately chose not to do it at that time in order, considering the hemodynamics of the patient. So thank you for your attention. And I'd like to hear what you might have done.